one.
Good morning, good afternoon, and good evening to everyone who is joining us from across the globe. My name is Magnus Conte. I am the Executive Director of the Community Health Academy. And on behalf of the Academy, I would like to welcome you all today to this webinar, which is focused on the timely topic of compensation and incentivization for health workers. Before I turn over to our moderator to lead us through today's conversation, I would like to give a brief introduction to the Community Health Academy and the context for today's event. The Community Health Academy is an initiative of Last Mile Health, which is intending to reimagine the education of community health workers and health systems leaders for the digital age. We are endeavoring to equipping 16,000 community health workers with immersive, interactive, up-to-date training tools deployed over smartphones by 2023. Creating also a global classroom to enroll and upskill over 10,000 community health systems leaders by 2021. Our first leadership course, titled Strengthening Community Health Workers Program to Deliver Primary Health Care, was launched on the 9th of May this year on the edX platform. To date, the course has over 8,000 learners enrolled from over 170 countries. This webinar that you are participating in today is part of a series intended to supplement the course learning and provide opportunities for learners and our global community to interact with and have their questions answered by course experts. Slide 2, please. With that brief introduction, it now gives me great pleasure to introduce the moderator for this event, Dr. Madeleine Ballard. Dr. Ballard has many years of experience in global and community health. She is also the Executive Director of the Community Health Impact Coalition and an assistant professor at the Icahn School of Medicine at Mount Sinai. She holds a PhD in Evaluation Science, University of Oxford, as a Rhodes Scholar, and was the founding program manager here at Last Mile Health. She currently conducts research on the efforts of effects of interventions to improve the performance of community health workers, and works with the coalition to catalyze the adoption of high-impact community health systems design. Dr. Ballard is a member of the Community Health Academy's Global Faculty Network, through which she advises the Academy in its efforts to build capacity among health systems leaders globally. We are honored to have Dr. Ballard with us here today. And with that, I'll now turn you over to Dr. Ballard to kick off the discussion. Thank you.
Thank you, Magnus. Hello, everyone, and welcome. Thank you so much for joining us today for a webinar on really one of the most hotly contested topics in community health delivery. For decades, insufficient incentivization has been cited in primary studies as a barrier to the sustainability and scale-up of community health worker programs. And while there's disagreement in the literature about the ideal form of compensation, that community health worker motivation must be addressed is not in dispute. The title of today's webinar, Because I Am Paid, I Feel Proud, is a quote from Ruth Tarr, a CHW in Liberia, who shared her story to policymakers and health leaders from around the world at the 2018 Global Conference on Primary Healthcare in Astana, Kazakhstan. And it was in Astana that the recent WHO Community Health Worker Guideline was released. The guideline recommends, quote, remunerating CHWs for their work with a financial package commensurate with the job demands, complexity, number of hours, training, and roles that they undertake. Yet, many community health workers, whether part of national programs or managed by NGOs, remain unpaid today. And so we are joined today by three fantastic speakers, all of whom are instructors on the Academy's first course, to explore the topic further, delving into the evidence, as well as the politics of community health worker payment. Now, the webinar is going to be structured as follows. For the first 30 to 40 minutes, speakers will respond to questions that we've gathered from all of you, learners in the Academy course. And then we'll take live stream questions from webinar participants. So please feel free to type your questions into the chat box at any point during our discussion, and we'll gather and respond to as many as possible nearer to the end of today's session. It now gives me great pleasure to introduce today's lovely panelists. From Ethiopia, we have Temesgen Ayehu, who leads the country's community health worker program called the Health Extension Program as the Director of Primary Health Care at the Federal Ministry of Health. From Liberia, we are lucky to have Dr. Bernice Dawn, who is now the Vice President for the College of Health Sciences of the University of Liberia and was the former Minister of Health in Liberia, who was actually instrumental in scaling and supporting Liberia's National Community Health Assistant Program. And finally, from the WHO's Health Workforce Unit, we have Dr. Giorgio Camedo, who led the development of the aforementioned WHO guideline on health policy and system support to optimize community health worker programs, and who has worked on health system development globally over the past 15 years. So thank you all for joining us. Thank you to our panelists. Now let's get started with the conversation. When it comes to payment, there are, of course, ethical questions, research questions, and political questions at play. And I'd love for us to cover all three in our conversation today. My first question, and this is to all three of the panelists, and perhaps you can all answer in unison, is in your current role that I've just described, are you paid?
Yes.
Temesgen, I think you're on mute.
Yes.
Thanks. I think just when discussing what others are owed, it's nice to begin with some transparency about what we are currently claiming for ourselves. So with that, Giorgio, the first evidence question goes to you. The WHO guideline recommends, as I noted, remunerating CHWs with a financial package. Can you briefly explain the steps involved in developing such a guideline, and then what factors underscored the rationale for the recommendation?
Yes, thank you, Madeline, with pleasure. So as with any WHO guideline, the development of recommendations follows a process whereby we start from scoping the purpose of the guideline and therefore identifying what policy issues are of most direct relevance to policymakers. For those issues that are prioritized, then we do commission systematic reviews of the published literature. And by published, I mean both peer-reviewed articles as well as gray literature and any other type of evidence that can usefully inform the evidence base. And finally, discussing the implications of the evidence and placing it in the broader context of the purpose of the guideline. So in this particular case, the systematic review that we found, that we developed, found some evidence that financial compensation did improve community health worker performance, satisfaction, and motivation. I must be transparent that the certainty of the evidence was rated as very low, meaning that both the quantity, the scope, the methodological strength of the studies identified had substantial limitations. For instance, all the studies were conducted in low and middle income countries. Many were not particularly strong from a methodological point of view. But overall, they all pointed in the direction of some kind of financial compensation being helpful, and both in terms of the health workers' perspective and preferences, as well as their performance and ultimately their result in terms of health systems expectations. In formulating the recommendation, however, it was not only the evidence that was taken into account. The guideline development group also considered other issues such as prevalent thinking and orientation in terms of labor laws, labor rights as enshrined in the international labor conventions, as well as broader human rights principles, gender considerations, taking into account that the majority of community health workers are female. And on this basis, not only it adopted the recommendation that you have just summarized, providing community health workers with a financial package commensurate with the type of work they do, but it also decided to adopt this as a strong recommendation in spite of the very low certainty of the evidence in light of the labor rights and broader health systems and gender equity perspectives that I just highlighted.
Thank you so much. And for those of you who aren't familiar, a systematic review is a type of literature review that uses systematic methods or very comprehensive methods to collect existing data, synthesize the findings, and kind of critically appraise the quality of that research. So we're not talking about the first 5 hits on Google. We're talking about teams commissioned by the WHO, looking up and down in every single database, contacting experts to try to find everything that's ever been published on this question. So it's quite a comprehensive process. And that was, as we heard from Giorgio, a key piece of what the Guideline Development Committee was considering when they were making this recommendation. So it's interesting that the guideline even had to make a recommendation around remuneration. I've been in healthcare a while. I've never heard arguments against paying doctors a salary or nurses a salary. And yet we routinely see that the poor, as Giorgio mentioned, often women, are asked to volunteer their time and labor as community health workers to secure their own basic right to health. Temesgen, why do you think that is?
So I think the first thing that we need to consider in compensating for community health workers is that the first thing is we need to appreciate the value of community health workers in improving health outcomes. And if we consider that community health workers will bring change in improving the health of the mothers and the children, then we need to consider also paying for the community health workers and also appropriate compensation for the community health workers. So I think that is also one of the rationale for Ethiopia to have a salaried community health workers, especially in rural areas, so that we believe that if we train and deploy community health workers with the required competencies, they will improve the health status of the community. So I think one of the reasons is we need to appreciate, or we need to value the contribution of community health workers in improving the health of the mothers and children, but also the health of the community.
Thanks. And Dr. Don, Liberia is also a country in which health workers are paid. How should community health workers' salaries be determined ideally? And how were they determined in practice in Liberia when you were the Minister of Health? I think you're on mute.
Liberia is a low-income country. And like most low and middle-income countries, there are serious challenges in providing healthcare for the population. And so you will notice that especially maternal and child deaths are significant in low and middle-income countries. And often governments do find innovative ways to provide healthcare for their population, especially populations in rural areas, because they bear the bulk of the death burden. In Liberia in 2012, the last government came into power in 2006. From 2006 to 2012, we had community health workers in communities providing healthcare services. But the system was so fragmented. So if you take the 3 Global Fund programs, for example, each one of them had their own community health workers, and they were paying them a minimum of $10 per month to do community health work. But there were a lot of NGOs, considering the fact that Liberia was also coming from war, that were providing services at the community level, that were of the opinion that paying community health workers was not sustainable. So there was this serious debate as to whether we should pay or we should not pay. Just within that time, Last Mile Health walked by and asked if it was possible to just test payments in one community, in one district, and see if that will work. So we agreed to that as a ministry. We went back to the demographic and health survey data for 2012, and we took the district that had the worst maternal and child deaths and asked them to work in that community to provide the evidence. Within 3 years, from 2012 to 2015, and if you notice that included the Ebola years also, they worked in that community to provide the evidence. And if you compare the evidence of paying them to the others who were not being paid, there was a vast difference. Maternal health indicators increased. Take, for instance, health facility delivery increased within that period like by 28%. Today, there are counties that are reporting over 90% health facility delivery. Child health. For children receiving health care in health facilities increased like 60% within that period. So we provided the evidence and called all the partners who were involved in community health to a meeting to relook at the policy. Of course, it was challenging, but we were able to get there. How did we set up the salary structure? We first looked at the minimum wage, which is about $125. We consider the number of hours that the community health worker will have to work. We knew that community health workers will have their own things to do, and so we put it at like 4 hours a day. And some calculations were done using that and the workload that was involved in providing the community health work, and that helped to determine the salary rate, which is about $70 per month. And that is what is being used currently in country.
Thank you so much for that phenomenal story of the transformation that took place in Liberia. It sounds like Liberia took the WHO recommendation to remunerate community health workers in line with the financial package commensurate with their job demands and complexity and the number of hours, even before that recommendation existed. So that's a wonderful story. Thank you so much. Temesgen, same question. How did Ethiopia go about determining community health worker salaries? How were those set?
Thank you, Madeline. So in Ethiopia, the community health workers, we call them the health extension workers. They are considered as civil servants, like the same as other health workers. So the salary of the health extension workers is set the same as other civil servants are set. So the main criteria to consider in setting the criteria is The first one is also the duration of their training and the level of the grade they reach, the health extension workers. So the first batch of the health extension workers, they are a 10th grade finish, and they receive a 1-year training. So one of the criteria is the duration of training, and the educational level is also considered as a criteria for setting the salary. So, and the other thing is also based on their experience and performance. Also, every 2 years, their salary will be revised. But the first one, the salary is set based on the experience, based on the educational level and also the work load that they are going to have. So, like for example, they are considered to provide service at the health post and also at the community and at household level. So, based on the workload and their level of education, the salary is set in the beginning. And like every 2 years, based on their experience and performance, the salary will be revised as part of also a career development. And recently, we are having a salary revision for the overall civil servant, and we use job evaluation and grading. And this job evaluation and grading will consider the workload, and we use a workload analysis factor to grade each workload. So the health extension workers' work is also graded using this job evaluation grading, and based on the workload and also the workflow and the type of work and the intensity of work that the health extension workers are going to spend, it is graded. And the overall civil servants' work is graded using the job evaluation and grading tool, and the health extension workers also their salary is also set using this job evaluation and grading tool recently.
Thank you, that's helpful. And that sounds like quite a sophisticated system. I think we're gonna talk more about the mechanics of how that actually unfolds on a day-to-day basis. One thing that learners were interested in though, and this is a question for both Dr. Dan and Temesgen, is what payment methods, cash, mobile money, and frequencies of payment are employed, and why is that? I know in Liberia, for instance, some health workers are very, very far from the nearest clinic, and that's sort of almost understood when we're talking about community health workers. So the logistics become a challenge. How have Liberia and Ethiopia met that challenge?
In Liberia, the payment evolved over time. But most of the rural payments at the moment is being done using mobile money. Using mobile money has its own challenges, but it also provided some formal way of payment for community health workers. The reason why there are challenges is because it's possible the mobile money is done on a district-wide basis. And community health workers live in villages where often mobile money is not very easy to do. But they do appreciate the fact that they are paid at the district level. And sometimes they organize their own means of getting that money to their communities. So that helps a lot. So the first payment method is mobile money. In some instances where there are banks, direct deposit is done into accounts. Cash payment is the last option because of the risks involved with paying cash. Even though at the moment, most of the community health workers that are being paid in cash are being paid by NGOs, and they have systems with trustworthy people who deliver the cash payment that is working well now and need to be considered sometime down the line, reconsidered when it should be turned over to the government and challenges that will be faced in the future.
Thank you. Temesgen.
Thank you, Madeline. So the payment mechanism in Ethiopia for the health extension workers. Currently, mostly we use a cash method because most of rural areas and also in some pastoral areas, the mobile money transfer is not common in Ethiopia. And the other mechanism is we also use in some urban areas to deposit their salary monthly through their accounts using bank methods. So the frequency of payment is mostly monthly in Ethiopia, monthly salary. And previously, the health extension workers were traveling to the district health offices to collect their salary. But recently, in most of the areas, health extension workers collect their salaries to the nearest health center, where they get frequent supervision and mentorship. So the good thing is when the health extension workers travel to the health center to collect their salary, they also travel with their monthly report, and they conduct a monthly review meeting at the health center level, and they also collect their salaries at the health center level. So it's also a good opportunity to have a monthly review meeting at the primary health care unit, where they previously get supervision visits, and the type of payment is mostly cash, especially in rural and pastoral areas.
Thank you, and that's a great point. Today we're talking obviously about payment, but what Temesgen said about leveraging different actions. If a community health worker already has to come to the facility to get payment, why not hold the monthly training meeting on the same day? I've heard similarly in Liberia, where if supervisors are going out to visit community health workers, why not restock them also on that visit? So I think getting creative about the different ways in which all of these types of support can work is a critical part of implementation. Shifting gears slightly, Giorgio, we heard from Temesgen that the health extension workers in Ethiopia receive, job evaluations and grading, and that's all part of the feedback and performance management that they receive as part of their jobs. That being said, there's also recently been a shift in the global conversation towards the question of performance-based incentives. So not paying a community health worker a salary and then mentoring them to improve their work, or censuring them if they haven't, but actually incenting them with monetary or potentially non-monetary payments to encourage specific health-related actions or the achievement of specific targets. Should compensation ever be conditional on performance? Why or why not?
Thanks. So this is a really important topic and one that we had the opportunity to explore through the guideline process. As a matter of fact, when I was mentioning earlier that the evidence that we found was broadly supportive of the notion of providing community health worker with a financial package, in reality, there were a few studies that pointed to some specific challenges, some shortcomings of a payment of community health workers. And all of those studies, in reality, referred to performance-based financing incentives. The challenges being of two types, two typologies primarily. One related to a poor conceptualization and design of these schemes, whereby CHWs, when incentivized to deliver targets relating to a single condition or even to a single indicator, tended to neglect other tasks, and that goes not just against WHO's positions on integrated service provision, but also against community expectations and health system needs. And this was seen as a substantial drawback. And then at a more operational level, that it turned out that paying people according to their performance is easier said than done, perhaps particularly so for community health workers. All sorts of challenges emerged in relation to effectively monitoring performance, to preventing corruption and mismanagement of performance-based incentives. So it is for this reason that in reality, on the issue of financial package and remuneration, in reality, the WHO guideline in reality has two recommendations. The generic one that supports providing a financial package to CHWs according to some of the criteria that both Dr. Dan and Dr. Temesgen was summarizing earlier. So the job type, the type of training, the complexity, the working hours, and so on and so forth. But there is actually a second recommendation cautioning against paying CHWs exclusively or predominantly according to performance-based incentives. Now, that doesn't exclude having a performance-based incentive component as part of the remuneration package. There are some experiences where this has been perfected over time and where it seems to be working. But broadly speaking, we should never forget that community health workers are not just a strategy. They're not a health system input. They're not our tool to achieve our quarterly or yearly target. They're people in the first place. They're young women, young men who need a livelihood, who need something to pay their bills, something to feed their families. And so it really goes against, it would go against all contemporary thinking of appropriate labor management relations if their entire compensation package were conditional on the attainment of performance targets that are inherently difficult to design and even more difficult to monitor. So this is an area where, based on the evidence we found, but also based on the interpretation of the Guideline Development Group, we wanted to also note a word of caution.
Thank you so much. That's a very comprehensive overview. Temesgen and Dr. Dan, we've talked a bit through the logistics of community health worker payment and the rationale for community health worker payment. But now I want to zoom out and consider the systems level. As we all know, and as detractors of CHW payment are fond of saying, money doesn't grow on trees. So how did Ethiopia and how did Liberia, as you mentioned, Dr. Dan, a low-income country, successfully mobilize resources, domestic resources and international resources, to be able to ensure that community health workers were regularly compensated? Dr. Dan, I think you're on mute.
Okay, thank you. Like you rightly said, resources in Liberia, in a low-income country, is hard to come, especially from the government side. The government envelope is small. Over the past 12, 13 years, it's been between 500 and 600 million dollars for the national budget. So that's how tight it is. So if we have partners helping with community health work, the first thing is to be able to use that resource efficiently. So because we're able to provide evidence supporting the payment for community health workers, we aligned all the partners. We actually mobilized all the partners to relook at our community health policy and strategy. And so the community health policy and strategy, a new community health policy was designed and the strategy was designed. And it required payment of community health workers as a policy. We asked and we aligned all the payments that partners were doing to the policy. So if you were not paying before you were supposed to start payment, if you were paying less than what we proposed, you were supposed to pay what we have proposed. If you were paying more than what we proposed, you have to bring it down and pay what the government proposed. Then we also map out where partners were providing support, and we try to reduce overlaps. Because we changed the strategy, we developed the curriculum for training the different modules. So everybody was using the same thing. So everybody incorporated their training program into the modules that were designed. And so it became mostly distributing partners geographically to be able to cover the country. Now, there were some challenges because we all know sometimes donor funding is there sometimes, and sometimes it is not there. Sometimes it takes some time to submit a new proposal, get approval, and then start again. And so we have been working with the partners to see how proposals could be submitted and cover counties. We have actually kept track. We kept track of funding sources and when funding will end, and try to encourage partners who have the ability to mobilize the resources, to cover up for counties or districts that funding might run out over a certain period. So we've managed to succeed with that to date to a good extent. Sustainability is a big worry to us at the moment because our community health worker program is highly donor supported. There are advocacies for government to consider the support, and there are other recommendations on other best practices like organizing them into teams and form entrepreneurs, look for seed funding, empower them, and start thinking on more sustainable ways of doing it. That might take some time, but at the moment it's donor supported, and we distributed the donors geographically, and we tend to monitor them.
Thank you. When it comes to sustainability, Ethiopia has been a leader in this. The Health Extension Worker Program has existed for many decades. Temesgen, can you share a bit on the same theme? How did Ethiopia mobilize domestic resources, international resources to ensure a highly functioning program and that the health extension workers continue to receive their salary?
Thank you. So I think one of the reasons that helped Ethiopia to mobilize resources domestically and internationally is also the evidence. We used to have a 15-year health sector development plan. It was started from 1997 to 2015, and it was divided in 5-year strategic plans. So the first health sector development plan was implemented from 1997 to 2002. So the evaluation of the first health sector development plan has shown us the access to basic health services was limited, and it didn't reach at the grassroots level. And also the expansion of primary healthcare facilities was low, especially in rural areas. And the distribution of also trained health workers was limited in urban areas. So access to primary healthcare was limited according to the findings of the evaluation of the first health sector development plan. And the other thing is the major cause of diseases and also illness was easily preventable diseases, and also which can be prevented through health promotion and disease prevention and some basic curative interventions. So these findings helped to convince the government to design this innovative community health program. And also one of the factors for sustainability and also mobilizing resources is because this program is government-driven, and it was also based on evidence. And that's why the government committed to invest on the health extension program. So based on these findings, and also through a government-driven innovative idea, the health extension program was designed, and it was pilot tested in some districts, and it was found effective. And based on this evidence, all the health extension workers were trained and deployed by the government. But we have another strategy, which is called harmonization and alignment manual of the health sector. So this harmonization and alignment manual has one key principle, which is one plan, one budget, and one report. So accordingly, the government mobilized donors and implementing in the countries through this principle. So every year and also every 5 years, the government, in line with those donors, will set priorities of the health sector in the country, and the government also will allocate some budget, and other donors also will allocate budgets through that priority setting process. And also they will implement the priority together. And we do have also one report mechanism, which is the health management information system, where every implementing partner or donor uses that platform as a reporting mechanism. And the other thing is also we use to, and also we review our progress annually through the annual review meeting of all the sector, where the government and all partners will participate. And the other thing is regarding the one budget principle. Previously, we used to have Millennium Development Goal Pool Fund, where especially some donors will put their budget into one pocket, and the government, together with those donors, will set priorities and use that budget. And I think the main factor, especially which helped the government to mobilize resources in implementing the health extension program, is the government showed its commitment by salary, by putting all these health extension workers in government salary. That's how other donors show the government commitment in implementing this health extension program, and that's why it helped us to implement, to also gain support from other donors, especially in training of the health extension workers, as well in upgrading of the health extension workers from one level to another level, and also in mobilizing donors to support the health extension workers with the required supplies and medicines as well.
Thank you so much. Giorgio, we've been talking a lot about financial incentives, which of course the WHO strongly recommends as part of the remuneration package for community health workers. But motivation is of course not only financial. What types of non-monetary incentives have shown impact for the motivation and retention of community health workers?
Thanks. This is clearly another very important element of the discussion. We know from the broader workforce experience and literature that the motivation of health workers in reality is multifactorial. It's not just remuneration that influences performance, but a host of other factors. Some of the aspects that we've looked into and which are reflected perhaps in other recommendations in the guideline span the full spectrum of health workforce interventions at every phase of the working lifespan, starting from the selection of the right type of trainees, people that have an intrinsic motivation to serve their communities, to receiving education and training in a respectful setting that addresses their needs and requirements. And then once they enter the active workforce, of course, remuneration may be a precondition, but there are a number of other factors that we can recommend on the basis of the evidence identified and that are reflected in different guideline recommendations, including issues such as receiving a regularly supportive supervision, being equipped with the tools and the supplies that are required to do their jobs, acknowledgement for their role and their performance. This can include the community feedback and support mechanisms, but also, again, taking the perspective of CHWs as people, as young aspiring professionals, also providing opportunities for professional development and career growth. This can be very context specific. In some countries, a pathway has been envisaged whereby CHWs, through experience and through successive training, can upgrade their job profile and status to progress to become other types of health workers, including nurses, including paramedical practitioners of different types. In other countries where maybe the educational requirements are different, this cannot be possible, but at the very least, it is possible to envisage a career growth even within the realm of community health service, for example, becoming senior CHWs or supervisors of other CHWs, etc., on the basis of positive performance and a positive track record. So these are some of the other broader health system factors that were considered. I know that a number of programs try to compensate for the absence of financial remuneration with in-kind incentives, be it in the form of bicycles or a bar soap or hats and t-shirts or whatever else. I think these may, in my opinion, and although there isn't necessarily a recommendation in the WHO guideline on this, but in my opinion, can be at best useful work tools. I don't think it would be appropriate to frame them as a replacement, as a substitute for financial compensation.
Funny anecdote. Thank you, Giorgio. I remember explaining to somebody outside the community health world this discussion about non-monetary incentives, and they asked, what do you mean, like housing or health insurance? And I said, no, hats and t-shirts. So again, I think your perspective is very helpful, that we frame these as young professionals, and we should be, honest about what's being provided and how that compares, of course, to other types of work. A question for all three of you now, before we turn to audience questions, of which we've received many, so thank you. When it comes to motivating community health workers, every person receiving a salary, receiving the tools to do their work, in time might find themselves becoming bored or demotivated, particularly if they've been involved for many years. What have you found, aside from providing a salary, aside from providing tools, to be the most helpful in keeping community health workers engaged and motivated to do their work? What strategies have worked in Liberia, in Ethiopia, or in other global contexts that you've been exposed to?
Well, thank you. The community health workers' salary normally is lower than the minimum wage, but we also gave examples. We gave you how we came to that. But in a village setting where there are no formal jobs, cash is difficult to come by. And so those salaries tend to create job opportunities for thousands of young people and women. So there's an economic benefit for that. It also tends to create a career pathways for them also. There are community health workers who worked with us during the Ebola crisis. They move on to be trained as surveillance officers, and now they are doing surveillance work. They do more of the surveillance work than what they were doing before as community health workers. I think is also provide the connection between the communities and the formal health sector, and that tends to gave them some satisfaction in being identified as part of the broader health sector. There are times that they go to the clinic, the catchment clinic, for their trainings and help to do other work there also, provide hands to do other things, and that helped to keep them around. I think the idea that we are even connecting the community, especially with the surveillance issue, also brings some social stability, especially when it comes to disease outbreak. And they feel a part of that also. So generally, they feel a part of the bigger healthcare delivery system and the contributions that they are providing to provide safety, to provide care, and to provide treatment for the population. The fact that they can grow from one stage and can consider, some actually also just get into the formal training program after some time and get back to school and come back to also provide healthcare, so providing the health workforce. So if we can continue to really identify formally the pathway for growth for them, I think it can keep them within the sector.
Thank you, Dr. Dan. And that's, of course, career pathways as one of the recommendations of the WHO guideline. Giorgio or Temeskin, before we turn to audience questions, other strategies that you might want to recommend?
Yeah, maybe to add some strategies besides the financial compensation or salary. I think the first critical intervention is career development. So, for example, in our setup, the health extension workers will upgrade from level 3 to level 4 to a BSc level. Recently, we started even a BSc level. And after that, they can upgrade to a master's and also above. So career development is one of the critical aspects to motivate health extension workers. And the other aspect is in-service trainings. So in our setup, the health extension workers receive regular refresher trainings to build their competency in providing the services, and also to update with new guidelines and also manuals. So in-service training is also in-service training in line with supervision is also another factor that will motivate the health extension worker. And the other thing is also promotion of the health extension workers to supervisory level, so that those health extension workers with the required level of education, like after upgrading, they can be supervisor to other community health workers. So that's also one of the factors that will motivate the health extension workers. And the other aspect, like if you ask most of the health extension workers, what motivates them is the respect they receive from the community they serve is one of the factors that the health extension workers value the most. And the other thing is also we recognize best performing health extension workers from each region annually during the annual review meeting conference. So that's also one of the factors that the health extension workers mentioned as a motivating factors to be recognized in national conferences and also regional conferences as well. So these are some of the non-financial motivating factors for the health extension workers that we are using currently.
Well, from my side, I don't have other particular strategies or approaches to add to the extensive list that Dr. Dan and Dr. Temesgen have already provided, which are exactly in line with some of the guideline recommendations that I was referring to earlier. But what I would like to add to this perspective is that I think we need perhaps to engender a paradigm shift in what we regard as success. Because I don't think when it comes to community health workers, what we really want is an 18-year-old boy or girl to be trained and then to remain a community health worker for the next 40 years. So complete lifelong retention is not necessarily what we want. I think we need to envisage things from a really a long-term perspective. Perhaps NGOs or development partners can afford a short-term perspective, but governments certainly cannot. Governments need to think 10, 20, 30, 40 years ahead, both in relation to what role they envisage for community health workers in the system, and therefore design an intake strategy and a training strategy that can envisage a progressive evolution of community health workers over time to best respond to health system needs, which may vary over decades, as well as adopting the same perspective to the individual life path of individual health workers, who therefore may be in a position to find attractive the position of community health worker at an entry level at the beginning of their career. And some of them may be content with that, but some may legitimately aspire to something different. And therefore, there should be a coherence between the design of various policies, from the intake criteria to the education strategy, the contracting arrangements, as well as the career development pathways that may be open to them to plan from the start for this type of evolution and growth also at the individual level.
Thank you so much. So we'll now turn to audience questions. The first question is for Temesgen, and we've received a couple of different questions around the Women's Development Army in Ethiopia. Of course, the health extension workers in Ethiopia are paid, but there's also another community cadre, the Women's Development Army, that are unpaid. And this raises interesting questions about volunteer cadres and how they work with paid cadres. I'd like to ask you, particularly in light of some qualitative evidence that was published in June of this year that found that these women were worse off than their paid peers in various psychosocial and economic respects and were vulnerable to high levels of psychological distress. To use Giorgio's framing, looking forward over the next 10, 20 years, what's the Ministry of Health's response to this evidence, and how do you envision health extension workers and the Women's Development Army evolving, if at all?
Yeah, thank you, Madeleine. Well, we have also seen that evidence. Actually, it was done in 2 districts, and actually we are also using that evidence to have a policy dialogue recently, which was held, I think, 2 months before, with relevant stakeholders on the overall implementation of the Health Development Army, its successes, challenges, and the way forward. And recently we are preparing and also presenting a policy brief on the Health Development Army, not only on the incentive and also remuneration aspect, but the overall performance of the Health Development Army, and also on strengthening the community engagement aspect. And one of the recommendations that we have put in that policy brief is on how to motivate these Women Development Army groups, considering also the large amount of Women Development Army groups engaging in this aspect. But also we have also recently conducting a national assessment on the health extension program. And one of the components of the assessment considers also the Health Development Army aspect. So like recently we are also conducting a recommendation formulation on that evidence, and the findings, like the preliminary findings, also this is a national also representative study, shows that actually the Health Development Army members are better off in wealth status than the rest of the members. But whether they are better off or not, we need to have the motivating strategies to retain and also motivate the Health Development Army members. And that's why currently the Ministry of Health and also with the implementing partners, we are designing a new strategy on how to optimize the community engagement aspect below the health extension program. And also one of the components of this community engagement optimizing strategies on motivating and incentivizing the Health Development Army. But we did, at this time, we didn't decide what type of strategies, whether incentive or non-incentive. But to mention the experience for in some districts, for example, they pay the community-based health insurance premium for this model community like for the model women development army members. So we are compiling evidences and also experience from these districts, and we will include what type of incentive mechanism we will employ to motivate and also to sustain the women development army in Ethiopia.
Thank you so much. It's a difficult challenge, and it's wonderful to see the Ministry of Health responding to new evidence and trying to find a way forward. We have a question from Tanzania, who is implementing a national community-based health program. I love Dr. Don for your thoughts on this. CHWs in Tanzania have been trained for 1 year. There is a shortfall in funding for salaries. And Chai asks how to best ensure that these community health workers are utilized by vertical health programs. You mentioned, Dr. Don, the Global Fund, the various programs, the chaos in Liberia prior to the emergence of a one national program. So what is your advice in terms of working with vertical programs and getting that money to support national community health workers and their training and their work?
Okay, thank you. In Liberia, it started with the policy reform. So the policy that was designed stated clearly community health workers should be paid. We also got the partners to agree on having an integrated training modules. So all the partners brought on the table the training modules, and the modules were redesigned to accommodate them. Then we based on, so for instance, we'll ask the Global Fund to support maybe NGOs within a particular county to be able to implement the package. Implementing the package means that they are implementing things that might be immunization, maybe supported by the malaria activities, plus other things. So that way the partner is satisfied that their activities are covered within the training modules. And then normally they do track the activities within the program itself. And one thing that we did was to also have an integrated supervision model. Though it was difficult to do, especially with the Global Fund, but there were many times also that the supervision was integrated. And so teams went out and did supervision for both those things that are supposed to be for Global Fund implementation, as well as the wider package itself. So it's a matter of bringing the partners onto the table. As a government, provide the directions for them in the form of a policy, and gave them the opportunity to align to the policy and implement your policy, your strategies, and your plans.
Thanks so much. We've also received a question around community health workers working in remote, hard to access, or potentially violent areas, receiving additional payment to compensate for the hardship and encourage them to continue providing care. Is that something, Giorgio, that you've seen practiced in any WHO member states that come to mind?
I don't think we ever come across evidence specific to CHWs in that respect, in the context of the guideline development process. Although there is broader evidence around what motivates health workers to accept posting and then retention in rural or otherwise hardship areas. And this is summarized in another WHO guideline. Now, again, this is not specific to CHWs, but broadly speaking, the evidence points to the most effective interventions lying in combining different strategies, of which indeed special incentives and allowances are a factor, but there are other equally important criteria, such as for instance, again, an expanded scope of practice or enabling and supportive regulation, supportive management systems, etc. All these factors combined can reinforce one another and improve the chances of retention of health workers in rural areas. Very important criterion, which we sort of take for granted for CHWs, is selection and membership within local communities. This is typically not the case for other types of health workers, but it is indeed the most prevalent practice for CHWs. But so these are some of the factors that would need to be taken into account. One point that I want to highlight specifically is the issue of protection of health workers from violence, from attacks, and this is something that we are increasingly concerned about. It is again not uniquely specific to community health workers, but that's something that no amount of financial incentives can or should compensate for. I think it is a duty of government or in the absence of government presence and capacity or willingness of the international community to protect health workers from violence and harm. And I think that's an agenda that applies just as equally to community health workers.
Thank you. And a follow-up question. It's interesting, Giorgio, you gave a very clear and reasoned answer earlier in our chat regarding the WHO's recommendation about performance-based incentives. The guideline suggests not paying community health workers exclusively or predominantly according to performance-based incentives based on the evidence. And yet we're getting still a number of questions about how to implement performance-based incentives. So can you speak a little bit to the persistence of this question? It seems to be something that comes up again and again and again, despite these clear policy recommendations.
Sure. I think the interest in the question probably lies in the fact that it is a prevalent practice to pay community health workers according to performance-based incentives. I should add that this was again a conditional recommendation based on a low certainty of evidence. And we did note that in context where this is being practiced with some success, that this probably shouldn't be stopped. And if anything, some considerations or special precautions should be taken into account in mitigating some of the potential drawbacks around this scheme. I think as with any performance-based incentive, I think this lies on a number of enabling factors. One of them is to have an efficient mechanism for monitoring performance, an efficient and transparent mechanism for monitoring performance, because one of the most demotivating factors for community health workers or health workers more generally is to see performance-based incentives being distributed according to other criteria, according to criteria of patronage, according to criteria of kinship, based on what in essence I could only describe as corrupt schemes. So having an incentive scheme depends on having an effective and reliable performance measurement system in place. It also relies on having efficient payment mechanisms, because whereas a regular salary whether it's called a salary, a stipend, an allowance, or an incentive. But if it's regular, it's predictable, and therefore it can be structured to happen automatically, whether it's by cash, whether it's through a bank transfer, whether it's through mobile money, as we were discussing earlier, but it's predictable. Whereas performance-based incentives, by definition, should be based on performance and therefore be variable. And therefore that introduces in the real world a whole set of issues relating to delayed payments, errors, or other administrative challenges, which again can be anticipated and prepare for. And perhaps the most important issue, at least from my perspective, without which the implementation arrangements really don't matter, is to have an appropriate design. We know that people respond to incentives sometimes in a positive way by engaging in the desired behavior, sometimes in a negative way by trying to game the system, for example, through false reporting, etc. So the way the scheme is designed is crucial. And in this sense, for example, we know that incentive schemes designed around one disease or one condition, one indicator will get people to prioritize that to the neglect of everything else. I think in this respect, the experience of Rwanda is, on the other hand, quite interesting because it is one country that seems to have gotten the question right in terms of how to design a performance-based incentive scheme and operating it with some success. What they're doing is to actually have a basket of indicators, and the performance is assessed not on one or two conditions, but on how health workers and even facilities are performing across a more comprehensive basket of primary healthcare services. So this at least mitigates against one of the possible risk of a flawed design of the incentive scheme. But then again, it takes capacity to measure the performance of community health workers across 16 or 17 indicators, as I believe is the case in Rwanda, or at least was a few years ago when I looked into this in more specific terms. And therefore, it does raise the issue: does the country have the required capacity to do that beyond the research setting or a quasi-experimental design? We've also seen that with regard to performance-based financing, there seems to be a difference between the result in small-scale trials, maybe well-funded, maybe with a high level of intensity in terms of monitoring capacity, etc., and the results when these are scaled up nationally or to a civil service setup where some of the same resources and capacity may not necessarily be in place. So I think some caution is warranted also when it comes to the design and implementation stage.
Thank you so much. That's a very helpful addition. The final question of today will go to Temesgen. We've heard from a number of different countries that, quote, do not have the funding to pay community health workers. But of course, we don't have the money is often less of a financial statement than a statement of political priorities. Governments fund all sorts of programs every day, even with very limited budgets. To close, what was the most successful argument used in Ethiopia to indicate that this should be one of those priorities, and that we do have the funding and can have the funding if we make it one?
I think the major factor is, as I've said previously, the evidence. So before designing the health extension program, as I've said previously, the assessment of the health sector development plan, the first phase, the findings that show that the distribution of primary healthcare facilities was low and distribution of health workers was limited to urban areas, whereas people were dying from easily preventable diseases. Helped to convince the government to design this health extension program to also train and deploy this amount of health extension workers. So one of the factors, as I've said, is the evidence. So I think if we present the right evidence to the government, it will help us in convincing to get funding from the government as well. And the other thing is also to show, to demonstrate the effectiveness of the program. So for example, in Ethiopian context, before scaling up the health extension program, it was pilot tested in selected districts and it showed its effectiveness. So showing the effectiveness of the program also will also help mobilize funds from the government, but also a government ownership and also putting the government in the driver's seat will convince also to mobilize resources from the government, but also from other donors, so that also if the government allocates also a budget for that program, the other donors also will be motivated to support the program.
Thank you so much. That's a phenomenal note to end on. I'd like to thank all of our speakers today for a really wide-ranging and insightful discussion. I'd also like to thank our participants for tuning in and for your insightful questions. I'm apologies that we didn't get to all of them. We've collected all the questions submitted today, and the Academy will review them and determine where we're able to sort of follow up and share answers back with today's participants. If you're interested in learning more about this topic or other topics having to do with community health research and implementation, there are 3 different ways that you can go deeper. The first is to sign up for the Community Health Academy's first course, Strengthening Community Health Worker Programs to Deliver Primary Health Care. And you can see that link right there on the slides. For updates on upcoming events, future courses, and other information about the Community Health Academy, the second thing you can do is sign up for the Academy listserv, also noted. And then if you want to just stay up to date, we talked about some of the new research that's coming out even as recently as June of this year in today's discussion. If you want to stay up to date on the latest research in community health, including questions about compensation, career path, supervision, things that topics that we've hit on today, you can sign up for the Community Health Impact Coalition's Community Health Research Roundup at that 3rd link for a fortnightly update on newly released community health worker papers. That's all for us today. Thank you so much again, and speak with you soon.